Many residents often feel in therapy that they need to be somehow blank, present a blank screen to the patient, show no emotion or no attitudes. Some of this may have come from Freud's metaphor of the therapist as a mirror in analysis. Well, it's absurd. Of course, we're going to show our feelings, our thoughts, our prejudices, our attitudes, and so on. Those things have to be recognized in ourselves, and patients can tolerate that too. It's a fiction that we should hide all attitudes, feelings, blank screen. It takes the therapist a long time to find out that the best instrument he has is his own self. He doesn't have to acquire something different. It's there all the time if he allows it to be uncovered and available to him. This is a tradition in medicine that the doctor diagnoses and prescribes, and the patient wants to be told what to do. But in dynamic psychotherapy, we more try to collaborate and join with the patient on exploring to find out what's what, rather than to be rushing off to try to change everything. There's a reluctance to bring up a discussion of issues such as lateness or cancellations, because fears that it'll drive the patient away. Actually, if the therapist is tactful and uses this as a way to understand what's going on, the concern is offset by one's sincere interest in trying to understand what's happening. I'm reminded of two categories of supervisors that I've become acquainted with, are very much like two different coaches for a football team. The one coach surveys the situation and sends in plays to the quarterback and tells him what to do. The other coach surveys the situation and helps the quarterback understand what's going on. He helps the person connect the dots to see certain patterns, and this allows him his own creativity in trying to work with his patient. And the patient is enlisted in this process. It's more of a collaborative approach than traditionally seen in medicine. When the therapists find themselves in rather difficult trouble in terms of their patient, their understanding, their management of their own anxiety and so on, they should not be reluctant to seek supervisory consultation from a trusted colleague. It can be a learning experience for the therapist, and it can be beneficial, certainly, for the patient. And it's a very useful device that we have available. We don't have to suffer through our difficulties in our work with patients. This is especially true in working with difficult borderline and psychotic patients. They elicit some of our most deep-rooted fundamental conflicts, as opposed to working with neurotic patients. It's as though some of the more basic aspects of ourselves are reawakened and challenged. And it does great things for your therapist's analysis, but it can be stressful and can be very useful to get supervisory help in such a situation. In a crisis, in an office practice, it's really a very good idea to have that.